So let's talk about the comorbidity for just a second. Because that seems to be an area of high exclusion for people of color, right? Obesity, diabetes. I'm curious if you've seen any movement towards, okay, we'll change our criteria to include controlled disease. Like if they're, the medication doesn't necessarily, contraindicate with the medication that they're testing. Have you seen that shift, or is it still a kind of a sticking point?
That's a big. I'm working on this cognitive impairment study where diabetes is an exclusion criteria, and it's because they're looking at that one has been very difficult to recruit in, and because the drug under test is a drug used for diabetes, we can't change the inclusion-exclusion criteria to allow it in a controlled situation. We've certainly seen a greater level of mindfulness from researchers in the earlier stages, thinking about the impact that specific wordings of inclusion-exclusion criteria are going to have on the ability to recruit. And we've certainly seen a willingness to put in requests to change inclusion-exclusion criteria based off of the challenges of recruiting patients. So I think there have been some efforts to that. It does, unfortunately, there are some situations where you just can't change them, which is unfortunate, but unfortunately the situation that it is.
How important is the principal investigator in enrolling clinical trial participants? What's their role?
Huge. The role of the site and the role of the investigator cannot be overstated. And we've consistently seen that it is maybe you'll have 10 sites, but 3 of them will get the majority of the patients. And that often comes down to the principal investigator himself is very personable or is really committed to the trial. There's lots of correlations that we have found between the time to respond to a lead. So sites that respond to a lead within 30 minutes recruit way more patients than sites that wait a day or two. And picking good investigators is key to trial success. Is certainly key to trial success, yeah.
How is patient eligibility determined for clinical? What percentage of your screen participants get accepted?
We aim for north of 50%. It really varies by trial and capacity. For some trials, it needs to be basically everyone needs to get in. It's a balance, because every time we add an extra question to our pre-screening, a certain percentage of people drop off. It's the same as buying a good online. If you buy a good online, there's a reason Amazon lets you do one-click purchase and it shows up in your house in 2 days. You're not going to think as much about it. You've got to flip through a bunch of forms. You're like, ugh, I'm busy. I got better things to do with my life. Particularly if you're using a not great, like cheap Android phone that doesn't have great web capabilities. You kind of just get aggravated and you just sort of leave. So every time we add a question, we lose people, and we lose people who might actually be eligible for the trial. So say if you have 4 questions and 10 people get through, and 7 of them end up being eligible. But say you add 5 questions and 9 people get through, but you might only get 5 patients. So it's a balancing act to make sure that you have the patient throughput meeting the site capacity. Oftentimes, how precise we need to be is really dependent on how much capacity the site itself has to screen patients more in depth. So some sites and some, investigators and trials are like, just send me, everyone you can get your hands on if you think there's a chance that they'll be eligible. We'll settle it and screen it. Other sites, it could be like, well, I've got 10 trials. I've got 10 trials going on right now. I need very accurate people because I just don't have the time to pre-screen. A clinical coordinator might quit, and now suddenly the capacity to pre-screen at a site is gone. So we need to tighten up there. Often it really comes down to the site's needs. And I think key to our success as a marketing firm has been really embedding ourselves with the sites, making friends, constantly getting feedback from sites. Oh, patients are failing. There's often patterns that sites can tell you. Patients are failing because they're on this specific medication that is contraindicated. Okay, we need to adjust the screening for that. So it's really just like embedding ourselves with the sites and making sure that the people, on the ground and on the front lines are actually giving us the feedback that we need. And oftentimes we also try to have those conversations with the sites without necessarily the central trial leadership being on those calls, because we can people can be a bit honest, are more willing to be honest with us when they don't have to sort of worry about how it might reflect on them or how they think it's going to get the principal investigators to think on us. And so it allows for a level of more sort of open court communication. And so it's about embedding with the sites and really making sure that we're attuned to local realities and local site needs.
To me, 50% doesn't sound, is that a good number, 50%?
It really varies on the disease state, to be honest. I would say the majority of those it really varies on the disease state and for the trial condition. We've been doing a fair amount in neurology recently. So like cognitive decline, Alzheimer's, that kind of stuff, where failure rates are way higher because the diagnoses are a bit more subjective. Whereas if we were just looking for people who had like diabetes and who were over the age of 50, like that is going to be way easier to find people for. And our failure rate for that should be 5%, 6%. It should be around there.
I'm curious what your relationship is with, I'm just wondering if relationships with primary care, you mentioned that briefly earlier, but how important that is in getting accurate information about potential participants.
Yeah, so for some like academic medical institutions that have like a hospital associated with them, sometimes those systems are very good at speaking to each other. And so that there is an ability for a primary care physician to like sort of to know of a trial and to recommend it to their patient. Obviously patients have privacy rights, right? Nobody wants to go to the doctor and have their private disease information sort of being shared around. So there's lots of restrictions from a privacy perspective, as there absolutely should be. There is some level of potential advertising capability within electronic like health records. Like sometimes we'll work in situations where it is allowable for us to send out a push through the electronic health records to patients who may be eligible, but there has to be like a lot of patients who are eligible, so there isn't like a data privacy issue. We can certainly identify physicians who might be heavily treating a specific disease based off of reimbursements for prescriptions that they wrote or medical services that they wrote that they billed to Medicare or Medicaid. If you write a certain number of, and the number is not available on top of my head, if you write a certain number of prescriptions for a specific drug a year and you bill that to Medicare, that is public information because it's tax dollars. Now we don't know who that prescription was written to, and there's a threshold, so we can't like re-identify it. But we can tell, this primary care physician writes tons of prescriptions for diabetes drugs, so they must see a lot of diabetes, particularly in states that have more loose, sorry, I say they allow for broader scope of practice of physician assistants and nurse practitioners. That kind of data can be very useful for identifying people who might be registered or consider themselves to be primary care physicians, but for whatever reason, they have, developed a patient base that has a specific disease state and they're known for a specific expertise. Oftentimes in New York, for example, allows for allows for, sorry, nurse practitioners to write scripts without a doctor's oversight and do a level of independent medical care that other states don't allow. And so oftentimes in this data analysis, we'll get the specialist for that condition, but we're also getting a lot of lists of, primary care physicians and nurse practitioners who are writing a lot of drug scripts for drugs that can be used to treat a specific disease. That can be useful for reaching medical professionals. We do, depending on the budget and depending on the disease, we will do a level of physician marketing. So that could be mail pieces, sermo advertising, LinkedIn, sometimes trying to get in front of professional associations and getting into professional association newsletters, doing partnerships with, or like really presentations to medical professionals when we can has been incredibly effective. And then oftentimes we found in the COVID in some trials that primary care physicians can not necessarily oppose clinical trial participation, but they can sometimes be a bit hesitant about it, and they will suggest that their patients not really do that, or they'll say that this drug is useless or whatever. And so sometimes we have to do advertising campaigns or education campaigns to local physicians in the area just about the existence of the trial, so that they've learned a bit about it before their patient has asked them about it.
I read recently that somewhere in the neighborhood of over 90% of doctors have no idea how to even navigate the clinical trial process, let alone get their patients involved in the clinical trial process. So I'm glad that you guys are advertising in that. Okay, so once enrolled, so now the patient is enrolled. They've passed the physical workup, all the exclusion criteria that now they're enrolled. What kind of support can participants expect?
Sure. So often actually one of the big benefits of clinical trial participation is that you get a level of like concierge medicine or access to the clinical researchers. And so you have a level of like ability to call the clinical researcher up to talk about your symptoms if you're having a flare up. You can often get to sort of jump the line in some ways. You get oftentimes a lot of clinical trials will come with, and one of the reasons why people do this is these full body workups. They're not clinical diagnoses per se, but you'll get a copy of your MRI scan, you'll get a copy of your full body scans that are done, any blood work done. It's not a clinical diagnosis, but you'll certainly be able to get a level of scans that would be tens of thousands of dollars if you try to pay for it purely in cash. You get a lot of access. How much patient burden varies by the trial. So for some trials we work on, you have 3 visits. Other trials you might have to show up every other week. It really varies, but oftentimes researchers make themselves very available to their patients. And so you get a level of like concierge attention that you just you wouldn't get if you just did through the regular primary care system.
So as far as patient burden, is there financial assistance for low income participants or their support person? Let's say the drug has, they require care at home, or they're sick from the effects of the drug, and does that person, the person who's caring for them, do they get, because oftentimes it's not just the person who has to take time off of work, right? It's the person who is caring for them who also has to take time off. There's also the consideration of the childcare. So when we're talking about this concierge medicine-like care, does that include that as well? Financial?
Yes.
For that?
So there are some trials where the medical care isn't free. That's rare. That's extremely rare. So in most trials, 90% plus, all the medical care is free. And then you get a reimbursement for sort of like time and travel. That is generally paid out to the individual participant rather than their like caregiver. I haven't seen a specific payment for caregivers. The financial reimbursements really vary by trial. They can sometimes be quite generous. And they can be a good chunk of money. During the COVID trial, actually, it was $445 for participation. And that, COVID would have probably knocked you out of your day job for a week or two. And oftentimes, if you got sick, your wife or husband also got sick. And so you'd get $900 generally if both of you signed up for the trial, for basically 7 days worth of work. The transportation, obviously the caregiver can come with transportation. The caregiver can obviously go in the free cab ride and come with the patient to the trial. But reimbursements are generally always given to patients and their to patients, and oftentimes the caregivers who accompany them are in the informal caregiver category, so they might be like a child or a family member of some child or spouse or family member of some sort. There isn't I haven't seen a direct payment to a caregiver yet, but that's actually an interesting idea.